Croup by Susie, Christine, Vanessa, Jody, and Bianca. Croup occurs in children from 6 months in age to 6 years. It occurs more often in boys than girls, and croup is more prevalent in the winter than in any other season. Most common causes of croup are parainfluenza virus. Other causes can be bacterial infection. Acute laryngeotracheobronchitis, or LTB, is the only form of croup that can be caused by either a virus or a bacteria. LTB affects children from ages 6 months to 6 years. It affects the vocal cords. It also affects the subglottis and the tissue below the vocal cords, including bronchi. Acute spasmodic laryngitis is found to affect children between the ages of 1 and 3 years old. Caused by a virus, or anxious children, emotional children, or excitable children, or children who are hereditally predisposed to have spasmodic croup. Swelling and inflammation is located in the subglottis. LTB has a gradual onset, awakens children at night with a harsh cough and inspiratory stridor. Children with spasmodic laryngitis are awakened suddenly in the night. These children wake with a harsh cough, inspiratory stridor, dyspnea, and hoarseness. Acute epiglottitis is caused by a bacteria, affects children between the ages of 3 and 7, has a sudden onset, can cause rapid airway obstruction which can lead to death. The location of the swelling and the inflammation for acute epiglottitis is the supraglottis. Acute tracheitis, a less common form of croup, affects children from ages 1 month to 6 years. Most commonly caused by staphylococcus, it progresses from an upper respiratory infection, and the swelling and the inflammation occur in the mucosa of the upper trachea. This is often confused with LTB. Pathophysiology of croup is the virus or bacteria are inhaled and infect the cells in the respiratory epithelium. This causes an inflammation response in the upper airway, which includes the epiglottis, the vocal cords, the trachea, the larynx, and the bronchi. In all forms of croup, mucosal inflammation and edema cause narrowing of the airways. The subglottic trachea is surrounded by the coracoid cartilage. With nowhere to go, the swelling is forced to move in on the internal airway of the larynx, which can lead to a narrowing of the airways. When a child takes an inspiratory breath, the walls of the subglottis space come together. This can lead to further inflammation, causing more edema and narrowing of the airways. This narrowing of the airways can induce further respiratory distress. Here is a picture of the inflammation of the vocal cords. Clinical manifestations of croup often increase at night. They can have a gradual or an abrupt onset. Fevers can be as high as 104 degrees. They can have a harsh, barky cough, sore throat, inspiratory stridor, nasal flaring, purulent secretions, dyspnea, hoarseness, use of accessory muscles to breathe, agitation, and cyanosis. This picture also shows signs and symptoms of croup. You can find this on our homepage. Diagnosis evaluation of croup. Croup is mainly diagnosed by clinical manifestations. CBCs can be done to evaluate the amount of white blood cells to determine if croup is bacterial or viral. Pulse oximetry can be done to assess the amount of oxygen saturation a child is receiving. They can also show signs of nasal flaring. You want to evaluate the color, rate, and effort of breathing. You want to have an evaluation of their level of consciousness. You want to evaluate their pulse rate, auscultate their chest and lungs, monitor the temperature to see if a fever is present, evaluate the throat and the neck. X-rays can be done to determine the amount of swelling and inflammation. And you can also use the Wesley's Croup scoring scale. This is Wesley's Croup scoring scale. A score of 12 or more means impending respiratory failure.